A single cellular disruption along a basement membrane does not stay isolated. It triggers a cascading biological attack, recruiting the immune system to systematically destroy its own structural boundaries. For decades, medical training has reduced this condition to a simple mnemonic, the 6 Ps: peritic, purple, polygonal, planar, papules, and plaques. But defining the disease strictly by its localized skin presentation misses the broader systemic threat. Lichen planus is a T-cell-mediated interface inflammatory disease. It is a highly coordinated, immune-driven assault targeted specifically at basal keratinocytes. Because these keratinocytes exist throughout the body, the T-cell attack can manifest in multiple anatomical compartments. The skin is only the most visible target. The scalp, the nails, the oral and genital mucosa, and even the esophagus are equally vulnerable to this inflammatory loop. The consequences differ drastically depending on the site. While classic cutaneous lesions often resolve spontaneously over 1 to 2 years, appendigeal and mucosal variants follow a much more destructive trajectory. They drive irreversible anatomical scarring, permanent tissue loss, and, in long-standing mucosal disease, malignant transformation. Recognizing the early phenotype in these vulnerable compartments is the only way a clinician can intervene and prevent permanent architectural damage. To understand the diverse clinical phases of lichen planus, we have to look at the primary pathogenic mechanism. This is an interface dermatitis, driven mainly by cytotoxic CD8-positive T lymphocytes migrating upward toward the basal keratinocytes along the dermo-epidermal junction. Interferon gamma acts as the primary driver of this assault. As it floods the junction, it orchestrates a complex signaling network, recruiting chemokines like CXCL9 and CXCL10 to accelerate and aggregate the T-cell response. This cytokine storm activates the JAK-STAT pathway within the cells, sustaining a localized, vicious inflammatory feedback loop that traps the surrounding tissue in a state of chronic immune response. Under this sustained signaling, the basal keratinocytes undergo targeted apoptosis. They collapse and condense into discrete, fragmented structures known as savate or colloid bodies. This microscopic battlefield translates directly onto a standard H&E slide. We see a dense, band-like lymphocytic infiltrate hugging the epidermis and obscuring the junction. Above it, the epidermal architecture warps, forming irregular, sawtooth rete ridges and a wedge-shaped layer of hypergranulosis. As the basal layer breaks down, the basement membrane loses its structural integrity. The melanin normally contained within the epidermis drops out of the damaged boundary and falls deep into the dermis. This pigment incontinence explains the deep, prolonged post-inflammatory hyperpigmentation seen in patients. Even after the active inflammatory loop is suppressed, the trapped dermal melanin leaves a stubborn, visible footprint of the attack. Every macroscopic symptom of lichen planus traces back to this specific microscopic event. The exact location and intensity of basal cell destruction dictates the outward clinical presentation. On the flexor wrists, ankles, and lower back, the classic presentation yields flat-topped, violaceous papules. Look closely at the surface and you will see fine white reticular lines, known as Wickham striae. These lines are the direct macroscopic visualization of the histological hypergranulosis we just observed. The disease process is highly reactive to environmental triggers. Mechanical trauma or scratching can induce basal cell apoptosis along the line of friction, creating a linear row of papules, a clear demonstration of the Koebner phenomenon. Zosteriform lichen planus presents in a distinct dermatomal pattern. This is an isotropic response. The inflammation localizes to an area of prior nerve damage, like a previous herpes zoster eruption, but is completely independent of active viral infection. The ratio of inflammation to pigment incontinence varies. While classic cutaneous disease is highly inflammatory, lichen planus pigmentosis produces massive pigment dropping with almost no visible preceding erythema, leaving symmetric slate-gray macules on the face, neck, and flexures. The most extreme variations of interface destruction present a complex diagnostic challenge, requiring strict differentiation between two completely distinct blistering presentations. In bullous lichen planus, the inflammational attack is so severe that the basement membrane separates entirely. Because the blisters are a direct mechanical consequence of interface destruction, they form strictly within existing violaceous lesions. Lichen Planus pemphigoides is a true autoimmune overlap where antibodies target the BP180 protein. Tense bullae erupt on both lichenoid plaques and clinically normal skin, and direct immunofluorescence reveals a distinct linear band of IgG and C3 along the basement membrane. The cutaneous phenotype reveals the precise depth and intensity of the basement membrane destruction. When the T-cell attack shifts to the hair follicle, it causes lichen planopilaris. Here, the inflammation specifically targets the upper permanent portion of the follicle, the isthmus and infundibulum, precisely where the follicular stem cells reside. Clinically, this produces perifollicular erythema and tubular white scale. Depending on the exact distribution, patients may present with patchy scalp alopecia or frontal fibrosing alopecia, characterized by progressive frontotemporal hairline recession and the loss of eyebrows. Because the attack zeroes in on the stem cell reservoir, the outcome is irreversible. Once the active inflammation subsides, the destroyed stem cells are replaced by dense fibrotic scar tissue, permanently sealing the follicular openings and precluding any future hair growth. The nail unit faces a similarly destructive threat. Inflammation at the nail matrix yields longitudinal ridging, thinning, and tracheonychia, while disease in the nail bed drives onycholysis and subungual hyperkeratosis. The hallmark of end-stage nail destruction is dorsal pterygium. The damaged proximal nail fold adheres completely to the underlying nail bed, dividing the nail plate in two and permanently disrupting normal nail anatomy. A rapidly progressive 20-nail dystrophy demands immediate intervention to prevent the permanent destruction of the entire nail apparatus. In appendigeal lichen planus, time is tissue. Delaying targeted therapy guarantees structural loss that no medical intervention can reverse. Mucosal involvement demands precise classification. In the mouth, asymptomatic reticular disease presents as bilateral, lace-like Wickham striae along the buccal mucosa. However, the erosive and atrophic forms drive painful ulceration, desquamative gingivitis, and severe difficulty eating. Chronic erosive disease in the genital mucosa drives severe mechanical complications, leading to vaginal narrowing, dense adhesions, phimosis, and urethral strictures that severely compromise function. We must also evaluate the often underdiagnosed systemic compartments. Esophageal involvement drives progressive dysphagia and stricture formation, while ocular mucosal scarring can permanently obstruct the lacrimal drainage system. Long-standing erosive mucosal disease, along with solitary, treatment-resistant hypertrophic plaques on the skin, acts as an active precursor pathway to squamous cell carcinoma. Any deviation from a stable phenotype requires triage. Persistent induration, a new verrucous area, unexplained bleeding, or progressive ulceration within an established lesion mandates an immediate rebiopsy to rule out malignant transformation. Chronic mucosal and hypertrophic variants require lifelong surveillance. In these sites, the interface inflammatory loop functions as an active driver of malignant change. Formulating a treatment plan requires assessing three variables: the specific anatomical compartment involved, the severity of the inflammatory loop, and the immediate risk of irreversible scarring. The therapeutic ladder begins with high-potency topical corticosteroids for localized cutaneous disease. Widespread, rapidly eruptive, or erosive mucosal presentations require escalating to systemic immunosuppressants, such as oral corticosteroids, methotrexate, mycophenolate, or cyclosporin. This visual tree illustrates the chart for targeted molecular therapy. Because the disease is sustained by interferon gamma signaling, utilizing oral and topical JAK inhibitors to block the JAK-STAT and TYK2 pathways offers a precise mechanism to shut down the interface dermatitis at its source. For resistant mucosal lesions, novel delivery systems bypass systemic absorption. Liposomal tacrolimus mouth rinses deliver high concentrations of active drug directly to the oral epithelium, suppressing local T-cell activity while minimizing systemic exposure. The clinical imperative is thorough examination. Regardless of the patient's primary dermatological complaint, you must evaluate the scalp, the nails, the oral cavity, and the genital mucosa. Recognizing the precise anatomical phenotype early allows you to deploy site-specific therapy. Breaking the T-cell loop before the tissue gives way is the definitive method to prevent permanent morbidity,
irreversible scarring, and malignant change.